Afternoon. Welcome everyone. Thank you for coming and giving us this time. I think there's a very worthwhile presentation prepared for you that I think we'll all benefit from. We have been, I want to apologize, less regular about these presentations because of some major schedule changes for the resident physicians that have happened this year. I was just telling Dr. Abir Chaudhary, who's been here probably as many times, many rotations as anybody in our program, that she would have been doing it every month if we'd just stayed on schedule, and I didn't even have to ask her if that was a good idea. So, but I think we're going to try very hard to get it back to a 4 to 6 week sort of arrangement. Still in the works. Anyway, thank you for coming and bearing with us. This is, if you haven't been here for any of these, this is a resident physician prepared presentation on a health topic of interest for older adults. Usually, you don't really want to hear that much about pediatrics, and we don't know anything about it anyway. So, and so the presenters are internal medicine residents. They're in their first 3 years after getting their medical degree, either MD or DO. It's good practice for them. For one thing, I think you'll agree that this is a worthy thing. It's practice for them to explain difficult topics in lay terms. We're not talking over people's head, and you use terms that we all recognize, so we want you to. So we devote half of it to the presentation, roughly, and then another 30 minutes for questions and answers. And we want you. And the questions and answers are really, really important, because otherwise we don't know whether we gave you the information you really wanted and needed. So I think you'll enjoy this. I want to introduce the residents who are presenting today. I told you it's a 3-year program. Dr. Chaudhary, who's sitting over here looking very relaxed because she's not presenting today. I told her she's on the bench. We may need to pull her in for some reason to substitute, but she's a third year resident, so she's just starting her last year with us. And Dr. Porshams, the one brave lone male here in the row, Ideen Porsham has been out here quite a bit. He's been assigned here, was probably here 6 times in the last year. We always enjoy having Ideen. Ideen's a native of California. Grew up in the San Jose area. Went to college at the University of California, Davis, medical school at Ross University, and did a postdoc fellowship at Stanford University before we snagged him and got him to come to Arkansas, to God's country. Yeah, I think he's been pretty impressed. And we've been impressed with him. So he'll be presenting. And then Dr. Jennifer George is a first-year resident. So just out getting into the postgraduate training, just her first 2 weeks are right here at Butterfield Trail. So I want to thank you again for the fact that it's a great experience for them, I think, to work with you as patients, those of you who see us in the clinic. And they learn a lot, and they are treated royally by people who live here. Such a gracious, I'll say this about all of you, almost without exception, how gracious you are and how supportive of medical education that this endeavor's been. I think it continues to be a really wonderful, strong partnership between UAMS and Butterfield Trail. I see it only growing in the future, and so thanks for your part in that. Well, Dr. George is from the Houston area, and let's see, college was in Florida, Fort Lauderdale area. And then she went to the University of North Texas for medical school. And then we were able to attract her to Northwest Arkansas. So I think you will enjoy their words. And again, thank you for coming, and make some notes of some good questions. Okay, Dr. George.
Thank you, Dr. Wright, and thank you everyone for coming to hear about our topic today, which is atrial fibrillation. And so I wanted to start off with going to the basics of what exactly is atrial fibrillation. And so atrial fibrillation is a condition of the heart where the rhythm of your heart is beating irregularly. So let's see if I can get this here. Maybe not. There it is. All right, so as you see here on the left side, we have kind of like a diagram of the heart. And the heart is contained of 4 chambers, 2 top chambers called the atria and 2 bottom chambers called the ventricles. And so when your heart is beating, an electrical impulse will be sent through, usually from the sinus node, and it gets sent down through these top 2 chambers and into the ventricles. And so each time that happens, that's when your heart beats. And if you've ever seen an EKG, that's how it shows up on an EKG. Now, in atrial fibrillation, this sinus node that's sending in these electrical impulses through the heart so that your heart will start beating is unable to do it in the regular way that it does. So it's sending these irregular pulses throughout your heart. And so what happens is your heart can't beat properly. It's beating irregularly. The top chambers aren't in sync with the bottom chambers. So I have a video, if we could get that playing. If Nathan's up there, maybe not, maybe. Oh, I see the thumbs up. All right, he's getting that going. So this animation really is just kind of showing how the heart looks when it's in atrial fibrillation. They'll describe it a little bit more in the video, but it shows how it's kind of quivering instead of a strong pulse to get your heart going. So let's see if we can get this going. Yeah, he gave me the thumbs up. Yeah. It is kind of how it looks if you were seeing a heart that's going through atrial fibrillation. So in terms of the causes and risk factors that are associated with atrial fibrillation, one of the most common risk factors is heart failure. So if a patient has heart failure, just from the changes that the heart goes through from heart failure, the heart may develop atrial fibrillation just because it has to go through a different rhythm, has to go through different electrical distributions as it goes down the heart. age for those greater than 65, the risk of getting atrial fibrillation is much greater. We've also seen that in women over the age of 65, they've also seemed to have a higher risk of getting atrial fibrillation. Part of that is also just associated with women having a longer lifespan, so you tend to just see more women with atrial fibrillation. Another risk factor and cause of atrial fibrillation is valvular heart disease. Now, there's multiple reasons why people get valvular heart disease, and not all of them will necessarily associate with an atrial fibrillation. But one of the most common is mitral stenosis, where one of the valves that the blood goes through starts to narrow. And because of the narrowing, the heart is working harder to push blood through, causing changes in the heart that can lead to atrial fibrillation. Some other risk factors include hyperthyroidism, chronic alcohol use, medications, sleep apnea, and diabetes. And one of the important reasons for knowing these risk factors is that for some of these, like hyperthyroidism, sleep apnea, if we can treat those causes, it's possible that we can resolve the atrial fibrillation and the arrhythmia that's happening. So a lot of the times, if you're going in to be seen in your doctor for atrial fibrillation, they'll also be doing labs to check for hyperthyroidism, if you have sleep apnea, and things like that, to make sure if there's an underlying cause, we can treat those and reduce your risk of getting more episodes of atrial fibrillation or even developing atrial fibrillation in the future. So what are the symptoms of atrial fibrillation? So some of these, as you can see, is fatigue, shortness of breath, dizziness, palpitations, and chest pain. Now, these are pretty common symptoms. You can see this in a variety of medical conditions. So I know you're thinking, oh, well, how would you know from this? Or even, what if you don't have any symptoms? Because that's possible. There are a lot of patients with atrial fibrillation that don't even know they have atrial fibrillation. So how would you figure out that I actually have atrial fibrillation if I am presenting with these symptoms? And so for the diagnosis, you have to get an EKG or an ECG. So for an EKG, what we are doing is trying to see what the activity of the heart is through electrical ways. So we'll put pads along your chest and have those pads read the electrical activity of the heart. And so for those who have not seen a normal EKG, let's see here. Here we go. So at the top is a normal EKG strip that we see. And so each of these sections is one normal heartbeat. And so as you can see here at the top, it's very normal, it's very regular. So this is coming right after the other, and we can almost predict when the next one will happen. And it's also very clear. You see these bumps here. This one's, if the atria or the top of the chambers are starting to get the impulse, we can read that activity. And then as the ventricles get that electrical activity, we see that. And then as it resets, it goes into a new heartbeat, and we can see that going. And this is all occurring within milliseconds. Every single heartbeat, we can see it. But in atrial fibrillations, we see that our patients aren't having this kind of regular rhythm that is going through. So we see that there's this irregular intervals between each heartbeat. Some are shorter, some are longer, and we can't really tell when the next one would technically start. Also, when we start our heart rhythm, it usually starts in the atrium, which we see here. This is how we usually know that the electrical activity is starting in the atrium. Here we can't even tell where it's actually starting, how much it's being given. It's not consistent enough. So if you ever see an EKG and someone mentions something along the lines of a flat P wave and irregular intervals, that's what we're seeing behind the scenes in, okay, this is why we think this is atrial fibrillation, because we're seeing this electrical activity that's showing that these patterns of atrial fibrillation. And so you can get an EKG done in the clinic or at the hospital. And usually it'll be over a few minutes, and we'll be able to get your electroactivity over those few minutes. But atrial fibrillation doesn't necessarily happen in just those few minutes. Sometimes it can start, then it stops again. It can come within a few minutes again, or it could come in hours later or days later. So how would you be able to actually know if you're having AFib if it's not consistent enough? What your doctor may do is send you with a Holter monitor, which is essentially an EKG that you can go and wear throughout the day in your day-to-day life. So on the top left picture, I have for you 2 Holter monitors. One's a wireless Holter monitor that you just stick on your chest. There's no wires on that. And then the Holter monitor with the wire is kind of the original one that we tend to use. There's a little computer kind of thing that you wear on your chest, and it's connected to the pads that you would see on a normal EKG machine, and that's able to record your EKG as well. And so you'd be able to take this in to your doctor or your cardiologist, and they'll be able to read it, and see if you actually had an episode of atrial fibrillation. Another option, which is more modern option now, is your smartwatches. I don't know how many people are wearing smartwatches right now, but some of the smartwatches that we have are able to detect your heartbeat, but also they're able to detect atrial fibrillation through an EKG app. Now, if you are wearing a smartwatch and it does tell you it sees atrial fibrillation, you should go in and tell your doctor about it. Don't just automatically assume you have atrial fibrillation. We'll go through and we'll probably set you up with the Holter monitor to double check and make sure. The smartwatch, while pretty accurate, is not our standard of testing in the medical field. We love Apple, but not that much. And so you'll see that if you get diagnosed with atrial fibrillation, there's different types and classifications of atrial fibrillation. Paroxysmal atrial fibrillation is when it ends within 7 days of starting. Usually there's no interventions like medications or any procedures, anything like that. It kind of starts and stops. Persistent, it's continuous for more than 7 days. Long-standing, you have continuous atrial fibrillation over a year. And then there's also a type of atrial fibrillation called atrial fibrillation with rapid ventricular rate. So while you have this irregular rhythm, some people develop this rapid heart rate that's greater than 100. And so with these patients, they're classified under atrial fibrillation with rapid ventricular rate. It can also go the other way, and you can have bradycardia too, so that you can have varying heart rates, whether it be normal or rapid in this case. And so as the video kind of mentioned before, the reason we're really worried about atrial fibrillation, one, I mean, yes, we don't want you to have an abnormal rhythm in your heart, but really with atrial fibrillation, it's a very common cause of stroke. And so the reason is that when your heart isn't able to pump properly, blood can kind of stay in your heart, and if blood is still, it has a tendency to clot. And when you build clots in your heart, if it gets sent to your brain or any other part of your body, but really for your brain, you can develop a stroke. And so I kind of wanted to do a quick reminder for everyone about what are the symptoms of stroke. And so that's face drooping, if you have any arm weakness, if you're having new speech difficulties. Those are all very common symptoms of stroke. And so if you notice yourself or anybody else with these symptoms, you should call 911 and get to the hospital to get checked out and possibly treated for the stroke. And so if you are diagnosed with atrial fibrillation, one of the first things your doctors will do is do a stroke risk assessment. And so this is what we use to kind of score our patients for strokes. So it's called CHAD-VAS scores, and it's an acronym of the different risk factors that could have a high risk for stroke. And so one of those is congestive heart failure, hypertension, age greater than 75, diabetes, stroke, vascular disease, an age of 65 to 74, and females. And so as you can see, there's different scores for each one. And on the far right, it shows what these scores correlate to your annual stroke risk. So a score of 0 is low risk for a stroke. A score of 1 starts to get into moderate, and 2 and above starts to get into high risk for stroke. And so when you're in these high risk or even moderate risk, we start to consider giving you medications and some alternatives to help you prevent stroke. And then this is another assessment that we do when we diagnose someone with atrial fibrillation. So prior to starting any treatments, we have to do a bleeding risk assessment. And so the reason for that is because in order to prevent a stroke, one of the treatments that we tend to give is a blood thinner. But we can't give blood thinners without knowing what's your bleeding risk, because everybody's different in terms of what their bleeding risk is. And so this is one of the assessments that we do called HAS-BLED. So HAS-BLED stands for hypertension, abnormal liver or renal function, stroke, bleeding, labile INR, elderly, and drugs or alcohol. And like the other assessment, each one has a certain amount of points with a maximum score of 9. And so if you have a score greater than 3, meaning you have 3 of these clinical characteristics, you're a high risk for bleeding. And so your doctor will consider that in terms of what treatments they're giving, how they dose the medications, how they want to slowly start you off, and double check more frequently in terms of getting clinical checks and medication managements with you. And so now we're going into stroke prevention. So I'm going to hand this off to Dr. Porshams.
Thank you so much. What a wonderful start to the presentation. Dr. George did an excellent job. Thanks for everyone coming out to listen to our presentation. We'll get into some discussion after a few more slides. But it's important to keep in mind that the heart has its own pacemaker. The sinoatrial node is in the upper right portion of that heart, and really that's what dictates the pace of the heart. That's the pacemaker. And then the structure of the heart is designed not only to be a muscle to force blood throughout the body, but it conducts the stimulation from that pacemaker throughout the rest of the heart, and it gives its normal rhythmic movement. And as we age or get exposed to heart failure or heart attacks, sometimes the electrical activity changes, but also the muscles can scar. And when the muscle scars, it's unable to conduct the electricity in a normal fashion. And we can discuss that more if it doesn't make sense. But once someone is found to be in atrial fibrillation, we test for it more often, we're aware of it more often, it's diagnosed more often because it's understood now to be dangerous because of the risk of stroke. In the past, somebody might have had atrial fibrillation and not been symptomatic, and the medical community would have thought that it was okay, that there was no risk. But as more evidence came out and the risk of stroke was attributed to atrial fibrillation, we realized we need to treat it and prevent these strokes from happening. So there are different medications now. Before, Coumadin or warfarin was used to thin the blood and prevent strokes. And again, Dr. George talked about how the stroke can manifest. If blood is not moving and remains stagnant, it clots. So if we cut our face shaving and we keep wiping the blood away, it'll keep bleeding. But if you leave it there, it should clot. Similarly, if the blood is remaining stagnant in that chamber of the heart, it can pool, it can form a clot, and then that clot can be pumped from the heart and into a vessel that causes a stroke. When Coumadin it came across some information about how Coumadin was discovered. It turns out that for a period of time, cows were being fed with hay that had grown mold. And when the cows were eating this mold, they were dropping dead in Wisconsin. So a farmer took his cow, as it was bleeding, to a veterinarian research center, and at the time it was called the Wisconsin Area for Research. WARF is what it stood for. That's actually where the term warfarin comes from. And they found out that the mold was causing the blood to thin, and they used that technology to then try to control the rat population. They would put it in poison, and then eventually it found its way to help the medical community. Our patients were treated with Coumadin or warfarin to thin the blood and prevent strokes. About a decade ago, new medications were used. The problem with warfarin is it's sometimes hard to control how effective it is. It can change by different things we eat in our diet, and the dosage needs to be balanced often. So we get blood work once a month to make sure that we're in a therapeutic range. But when these new medications came out, they were more stable. Patients no longer had to get tested every month. It became more suitable for patients to conduct their lives without getting labs every week. Their therapeutic range was more balanced. And these medications have these names that you've probably heard of. Eliquis is the one at the top right here. Apixaban is the generic name, Eliquis is the trade name, and there are other ones that can be used. Xarelto, Rivaroxaban, of course, we still use warfarin. There are some advantages to warfarin. For example, God forbid you fall down and you hurt yourself and you're bleeding, warfarin can be reversed more easily, but there are now reversible medications for the other medications as well. For the direct oral anticoagulants, they call them DOACs, or new oral anticoagulants, NOACs. So these are the different options that we have. So when you do meet with your physician and you're discussing these anticoagulants, these are the different options, and we can discuss more if anyone has any questions about these. Now, if a patient cannot take an anticoagulant, there are some structural options that can be implanted in the heart. So in the left atrium, there's a pocket called the left atrial appendage, which is like the appendix, a rudimentary piece of anatomy of the heart that allows blood to go and become stagnant. Options are to close that appendage or to put a device that closes it off. So you can surgically suture it closed, or through the groin, very minimally invasive, you can put something called a Watchman. And a nice picture right here, this is the left atrial appendage. This is the left atrium. The blood from the left atrium is coming from the pulmonary vein, from the lungs, so it gets oxygen from the lungs, comes back from the pulmonary vein into the left atrium, goes down into the left ventricle, and then through the body. But this left atrial appendage creates a bit of a problem because as blood comes into this area, this is the area where it has a high likelihood of forming a clot. So this Watchman device essentially closes off and prevents these clots from entering the systemic circulation into the body, going to the brain or to cause a clot in this example. Does that go to the next slide? Okay. So another treatment is cardioversion. So essentially, if the heart is in atrial fibrillation and we want to reset the circuitry of the heart, we can do what's called a cardioversion, which under sedation, to make the patient more comfortable, a shock is delivered to the heart to reset the electrical activity. So you can see here in this picture, there is a machine with stickers on the patient's chest, and after some sedation, this machine resets the heart and the electrical activity is placed back into normal sinus rhythm. Sinus coming from the sinoatrial node, the natural pacemaker of our heart, and normal sinus rhythm. Dr. George very nicely went through that rhythm. So that shock should set the electrical activity back into normal sinus rhythm, and it can sometimes go back into atrial fibrillation. So once this is done, the patient is continuously monitored to make sure and ensure that they remain in that normal rhythm. And it's true, the patient can go home the same day. Usually your loved one is waiting in the waiting room and drives you home. Some other options are available for treatment, and it really depends on how often you're in atrial fibrillation. We went through the terminology. When someone first presents an atrial fibrillation, they may not have any symptoms, or they may get an EKG and not be aware. If it's short term, coming and going, intermittent, we call it paroxysmal. And as it becomes more persistent, it can then become permanent atrial fibrillation. And the level of treatment, whether it's just medication or a device being placed or electrical resetting, really depends on how often the patient is in atrial fibrillation and also how symptomatic they are. Are they having trouble breathing? Are they having this constant palpitation? Is it becoming something that prevents them from normal activities? So going back to the cardioversions, these are the reasons that a patient would not be cardioverted. Age-related, and also, as we mentioned, if it's paroxysmal, if it's just a short duration and will resolve on its own, we wouldn't go through a cardioversion electrical shock to treat a patient. And also, if the left atrium of the heart is enlarged, the cardioversion is not the best option for treatment. Now, different medications are used, and it comes down to a lot of research is being done, a lot of publications are coming out to determine whether treatment should be based on rate or rhythm. So, again, Dr. George was going through the rhythm of the heart. When a patient is in atrial fibrillation, sometimes the rates can be elevated. Our normal rates should be between 60 to 90 beats per minute. And once you get over 100, it's considered tachycardic. Patients in atrial fibrillation can have rates as high as 120 to 160, and it really becomes dangerous. And the rate at which the heart is beating needs to be controlled. And there are different medications for that. Beta blockers, which you may have heard of, for example, metoprolol or carvedilol, and calcium channel blockers like verapamil and amlodipine. These are options for rate control. Digoxin is also an option. I don't know if anyone has been on digoxin, but it's prescribed less often. And then there's rhythm control. So first we're talking about trying to bring the heart rate down, and the other options are to try to control the rhythm. And these medications can be effective up to 60% of the time. So just because you're taking the medication for rhythm control does not mean that it's surely going to keep you out of atrial fibrillation. And some of these medications actually have some significant side effects. These options include flecainide, propafenone, amiodarone, and dofetilide. Some patients, some of you have probably been on some of these medications for a time period or on them now. But the research is still out. Some studies have shown that rate control is superior to rhythm control, and some have shown that rhythm control has some superiority. But in the end, it really depends on the conversation that you have with your physician in a shared decision-making capacity to determine how active you are and how symptomatic you are to see exactly would it make more sense to control the rate of your heart or to try to control the rhythm and keep you out of atrial fibrillation entirely. And we kind of discussed some of these parameters. So with your physician, you'll look at how old you are, how symptomatic you are, how active you are. If you have any other contraindications like coronary artery disease, if you're able to tolerate a cardioversion with the patches that deliver the shock. And also, if you have congestive heart failure, you might be more suitable for rhythm control. So these are all of the different types of parameters that you would discuss with a cardiologist to determine what the best mode of treatment would be. And in 1982, at the University of California in San Francisco, the first ablation was done. And the concept behind that was, after a lot of research, they determined that atrial fibrillation had a lot of cause due to ectopic electrical activity coming from those pulmonary veins. So the veins from the lungs bring oxygenated blood back to the left atrium. And at the opening of those veins, including somewhat inside those veins, they were finding electrical activity that was causing atrial fibrillation. So the thought process was, if we go in and scar that area, perhaps it'll stop the electrical activity and prevent the heart from maintaining this incorrect electrical stimulation. So the first ablation was done in 1982. Since then, the technology has gotten a lot better. Now through the groin, through the veins of the groin, not even the arteries, catheters are placed. So with 2 punctures on each side of your groin, catheters are placed, and a map is created of the anatomy and the electrical grid pattern of the left atrium where those pulmonary veins are entering. And throughout a course of an operation that may last 2 to 4, sometimes 6 hours maybe, the doctors will meticulously map out the electrical activity of that area and go in and either with radio frequency or cryoablation, essentially freezing that portion of the heart, they will basically kill that portion of the muscle and tone down the electrical activity. They will scar it so that it doesn't have the incorrect electrical stimulation anymore. Sometimes patients will be out of atrial fibrillation after one ablation procedure. Sometimes it will restart atrial fibrillation and they'll go back and do it again. The way that they enter the left atrium is through the right atrium. They actually poke a hole through the wall separating the right atrium and the left atrium, but within 1 month, that hole actually closes up, it heals. When they do a subsequent surgery, actually, it's harder to poke that hole because it has formed a scar tissue at that area. But some patients could have 3 ablations just to have this controlled. And you can see from some of these pictures here, this is the catheter that was brought from, so this is coming up from, let's imagine your groin is down here, up through the vena cava, through the right atrium. They poke this hole right here and come into the left atrium. These are the pulmonary veins that are entering, and these little stars represent where all of that incorrect electrical stimulation might be coming from. So they will create a 3-dimensional map and determine exactly where those electrical stimulants are coming from, and they will use these catheters to essentially burn or freeze with radiofrequency or cryoablation those areas of the heart to tone down the electrical stimulation and prevent the heart from being in this constant atrial fibrillation. And then, of course, pacemakers. At some point, if the area of the heart where it has its natural pacemaker is affected to the point that the heart rate is so low that it doesn't sustain our activity level, then a pacemaker is placed to make sure that it's high enough to tolerate activities. So after conducting a procedure, if the heart rate is down to the 40 beats per minute, at that point you can place a pacemaker to ensure that the heart is maintaining a certain beat per minute that is sustainable for the activities that we do. Oh, we have a video. Fantastic. If you don't mind, we could start this video as well. And the pacemakers can be different too. They can have multiple leads depending on the requirements of your heart that you have a discussion with your cardiologist. And the pacemaker can be placed in this upper area of your chest, and the leads can be placed into one ventricle or in 2. I'm not sure if we're going to get this video started, but I might have gotten busy, I guess. It's okay. But essentially, that's the reason that we put the pacemaker slide, because patients who undergo ablation may have a heart rate that is too low, and that's why the pacemaker is placed. So we would love to get into some discussion now. But before we do, I just wanted to explain again that having atrial fibrillation does not mean that you cannot exercise. It doesn't mean that your activity level needs to be suppressed. A lot of people go into the doctor unknowing that they have atrial fibrillation. The EKG may show it. And really the concern is, do we have to treat for a stroke? Now, statistically, if 1% of the population was at risk for a stroke with atrial fibrillation, it still is a wise idea to take anticoagulation, because 1% of the population is millions of people. And the risk of having a stroke, it doesn't mean that just because you have atrial fibrillation, you now have a risk of stroke. It could be a 5% risk per year. It could be a 1% risk per year. Again, that depends on your age, your genetics, your gender, being female or male, your other comorbidities, such as whether you have coronary artery disease, diabetes, or any type of vascular disease. All of this together creates a picture on whether there's a risk high enough to take anticoagulation of blood thinners to prevent a stroke. But it shouldn't be taken from this conversation as just because you have atrial fibrillation, you now are destined to have a stroke and you can't have normal activity levels. Just want to make sure that is clear. And a lot of research is still ongoing about treatment, different medications, because those medications that control the rhythm really have a lot of side effects, and they might be effective only 60% of the time. But if a patient is really not feeling well because of the atrial fibrillation, that's when the decision is made to actually take the medication and try to maintain a normal heart rhythm rather than that quivering. And when we say quivering, you could think of it as if your eyelid was twitching. You could imagine your heart is actually twitching like that. It's not effectively pumping. So that's really what we're worried about. If it's not effectively pumping and the blood is remaining stagnant, that is when the blood can pool and create a clot. Anyone have any questions? Yes, please. Thanks, Dr. Wright.
I guess 2 questions. So aside from the correlation with age, why would the sinus node be going haywire? You sort of mentioned the pulmonary arteries or veins may have something to do with it. Do we know anything else about that? Also, beyond the risk of stroke, what are the long-term risks of the heart simply not pumping properly in other systems?
Yeah, so in terms of your first question about why the sinus node would stop working and why these pulmonary or these electrical impulses come from the pulmonary veins. So some of it's not fully known exactly why it stops working, but with these risk factors we have, like Dr. Porshams mentioned earlier, if say you have heart failure or anything that's affecting your heart, the muscles of your heart can change, and when those muscles change, the structure of your heart can also change. And so the electrical pathway that your heart usually takes to send these impulses throughout your whole heart, those paths will now have to divert as the structure itself is changing. And then your next question was about, I'm sorry, what was the second question that you had?
So the function of your heart declines as we age in general, is that right?
Oh, how does it affect everything else?
So if we can limit stroke risk with Eliquis or something like that, still, what are the other systems in your body that might be affected by the heart not pumping properly? Kidneys, liver, I don't know.
Absolutely, the kidneys are important. But in general, if you're going to be someone who's active and exercising, you're going to need proper blood flow. But yes, the kidneys are very sensitive to proper blood pressure. But really, the biggest concern is that this clot can go to your brain and just severely limit your life with a stroke. But throughout the rest of the body, yes, we need proper blood pressure and heart function just to be able to walk up a hill without getting short of breath or dizzy. But really, the main concern is we're trying to maintain the brain. That's the big concern with these strokes. Yeah.
Other
Is it possible for AFibs to be inherited? That it's part of the DNA some way? I'm asking because in a family, the father and mother have had AFibs. Each one of the 3 children has had AFibs. So it's not related to male or female, but it is consolidated within this family.
I would say there's a strong genetic component. Based on my research over the weekend, they have not really identified the actual gene that can be tested for to say you have this gene that's related to atrial fibrillation. But when you look at the pattern of, as you said, family inheritance, there is a component. But everything is still being tested, even alcohol right now. There have been studies with acute alcohol use, meaning someone goes out and has a alcohol binge and develops atrial fibrillation. They then did studies to see of people who have alcoholism, how often or what is the link to atrial fibrillation in those patients. And then they had certain patients who have had alcoholism abstain from alcohol, and some people were able to prevent atrial fibrillation. But again, these are all studies that are new. So, but to answer your question, yes, there's a genetic component, but other links are being studied as far as age, I think, is one of the predominant factors because as we age, just the heart muscle changes, and when it does, the electrical activity can change as well. The good news is that caffeine was tested, and caffeine did not have a strong link to atrial fibrillation. But even sleep apnea, just being unable to properly breathe at night, is linked to atrial fibrillation. But yes, to answer your question, there is a genetic component, but hasn't been identified as far as the exact gene yet. You're welcome.
And to add on that point, even though we don't have the exact gene of what causes atrial fibrillation, we do know that atrial fibrillation isn't just for people over the age of 65 or 75. There are, although not as common, there are younger patients who have atrial fibrillation. So for those younger patients, there seems to be a stronger genetic disposition to if is there a family tie to it, just because why would they develop it at a younger age compared to the majority of the population who is getting atrial fibrillation when they're older at 65 or 75. So yeah, there's definitely a potential cause that we're still looking out for. So we might find it one day, but for now, that's what we have now.
I referred my brother when he was about early 50s, to a cardiologist because found him to be in atrial fibrillation. And I thought, this is good. I know that cardiologist. He's very conscientious. He'll ask the right questions, and he'll uncover the fact that he's a really big beer drinker. He's going to take him off that beer. And that's what my brother reported. Yeah, he took me off beer. I said, well, how are you doing with that? He said, I'm just as good with wine or vodka. That's not a problem. I said, you got to help him here. You got to work with him a little bit. This is about your health. He wound up having 3 ablations that really didn't work ultimately for very long. And then he finally did what I'd asked him to do for about 10 years, and that's get a sleep study, had sleep apnea. And once he got on CPAP, his atrial fib went away. This is over about 8 years. Stubborn patient. That's probably genetic too.
Is there ever an emotional component? I'm thinking my father had his first AFib attack in his late 40s as a time of severe emotional.
Well, I don't know how much it's been studied, but I think most doctors would say anything that created high stress, if you were predisposed genetically or otherwise, predisposed to atrial fib, even if you didn't know it before, that could be a trigger. Y'all have any other information on that?
No, I mean, absolutely. I think stress or any strong emotional component can definitely trigger either an episode if you never had it before, or if you you have a diagnosis, it can also trigger a new episode of having another atrial fibrillation. So yes, I believe so.
And then beyond atrial fibrillation, there's this term called takotsubo. At the bottom of the heart, it has the shape of what Japanese people describe as a vase or a pot where an octopus would go in and hide. And they correlate the shape of that bottom of the heart with takotsubo. I think subo means vase and tako means octopus. And the shape of that part of the heart, they've noticed that when someone has a severe emotional response, that part of the heart doesn't conduct electrical stimulation. So you have the bottom of the heart, not the top where atrial fibrillation is related, but now we're talking about the bottom of the ventricles. And because it doesn't function correctly, you're not getting proper blood flow. So to correlate an emotional response with takotsubo, I'm sure there might be a link to atrial fibrillation as well. But as far as with our studies, they've taught us that takotsubo is related to a severe emotional response. When someone has just stricken with grief, they might do an echocardiogram and see the bottom of the heart is not moving rhythmically as it should. The top of the heart is propagating the motion, but at the bottom it's not moving. And that bottom has that shape of a vase. So if there's a correlation with atrial fibrillation, we haven't come across it, but we believe it. There must be some correlation with that.
This refers kind of to your brother. I was going to ask, what happens when you have an ablation and it doesn't work? Do you just go have another one, or is there a time limit? Or
I think there are times when they would be able to tell that another one wouldn't work either, but a lot of people wind up giving 2 or 3 ablations. By the time they're getting 3, there usually has been some partial response to encourage them to try yet again, but there's a limit. I know quite a few people who've had as many as 3, and so it's not perfect. But when it works, I haven't heard more than 3.
I haven't heard more than 3 either. Yeah.
Maybe it's just because a person wouldn't hold still for a 3rd or 4th one. I'm not sure.
The main reason I wanted to say something is this, and that is that over time we have really had some wonderful presentations from the residents who are doing their rotation here. But I think that this presentation on atrial fibrillation this afternoon, if not one of the best, is the very best that we have ever had.
Thank you so much. We really appreciate it. Really appreciate y'all's intention. We love it when there's a audience who's really engaged in all of this. So thank you.
Well, it's very relevant, of course, to this audience. You answered the question that I had, and that was this little bundle that is the a derivation of the impulse is a little bundle of nerves. And I was wondering what threw that nerve control off, and you've answered that. Thank you. One of the things that I wanted to ask is sort of a simple question, but it's true that if your heart is racing or you feel that there's a little bit of irregularity, sometimes just by deep breathing, you can get it under control again. I wonder if, for example, you were waked up at night or were someplace where you couldn't get right away to a doctor and might be having a little trouble with atrial fibrillation, if deep breathing would help at all. And what is it about breathing that can control the heartbeat anyway?
Yeah, no, that's a great question. So in terms of breathing, when you can do deep breathing, you're able to stimulate your nervous system a little bit, and sometimes not necessarily solely related to atrial fibrillation, but with deep breathing, you can somewhat control your heart rate and kind of slowly lower it a little bit. So if you're feeling these palpitations and things like that in the middle of the night, and you take a couple deep breaths, you might start slowing it down, having your heart kind of just somewhat reset itself in a sense. Of course, if you are having these episodes of atrial fibrillation, or what you may be thinking is atrial fibrillation, and you're having these symptoms, we definitely recommend that you go see your doctor and let them know that you're having these symptoms so they can do a full workup. Because as we said, those risk factors, while atrial fibrillation can be a cause, if it's something more related to sleep apnea or anything like that, and we can get it treated, or if it is atrial fibrillation, we can get a diagnosis for you and get you properly treated so you're not dealing with those symptoms at any point of the day, whether you're sleeping or awake.
Yes, sir.
What's the side effects of ablation where you kill a part of the heart? Is one question. The second is, does a pacemaker not have any effect at all on AFib? And the third is, I assume that if you're taking blood thinner, that a stroke is very unlikely from AFib. Is that true?
Yeah, so in terms of your question for ablation, what are the risks? There's, of course, always a risk. This is an invasive procedure. We are going into your heart, so there's always a risk of bleeding, of thromboembolisms from just doing the procedures itself. From the scarring itself, these ablations that we're giving, these tiny scars, it's a very small part, and they're very calculated to where exactly they're ablating the heart. So when they're putting the catheter in, they are able to get impulses from the heart and see that electrical activity to know exactly where they are. So they know that they're at these pulmonary veins that are sending these abnormal activities. So when they put those scars, it essentially it's kind of like a roadblock stopping the electrical impulses from passing through to make that irregular activity. Not the overall function of the heart, it doesn't kill any of that. Since it's such a small portion of the heart, it's not going to affect the way your heart moves blood or is able to pump at all. In terms of your question about the pacemaker, so the pacemaker itself is more about preventing your heart from beating too slow. It won't have any effect on atrial fibrillation at all, which is why you may be on a pacemaker, but you'll also either had an ablation before or you're possibly on some of the medications that we talked about to control the actual atrial fibrillation. But the pacemaker, if your heart starts to beat too low, the pacemaker is able to get that signal and send a little impulse to your heart, so then it can start speeding up the heart rate so you're back to a normal rate. And then the third question I've already forgotten, but yes, yeah. So a pacemaker, yes, it doesn't have an effect on the atrial fibrillation itself, just more on the heart rate.
You know, we may not have made a big enough point about it, but in addition to atrial fibrillation being a rhythm that's just irregular, it's often called, it's described as irregularly irregular. There's no cadence to it. It's just very irregular. And it wants to go too fast. It wants to go too fast. And the reason so many people have pacemakers just as Dr. George said, it doesn't really treat the atrial fib, but in treating the atrial fib to get it under control, under rate control, you know, for older adults, often no matter what you do, ablations, the other medications that can put it back in normal rhythm, you're more likely to stay in it ultimately or come back in it later and not be able to get out of it. But the saving thing is that if you can get the rate slow enough, person can feel fine without it. Trouble is, and you know about beta blockers like metoprolol and there are several of them, those slow the rate. It keeps it from going too fast, but then it'll be too slow, and that's where a pacemaker comes in. And so that's why it seems like most everybody who has atrial fib very often or very prominently winds up with a pacemaker, just to protect it from going too slow. So, sorry. Yeah, two over here.
I'm just asking, what does it mean when you're told you're in controlled AFib, but you're not taking any medications? The only thing you've done differently is take Eliquis.
Well, I guess if the atrial fibrillation is controlled, then the medication is either keeping the rate low enough to prevent it from being so high that it's dangerous. Because it's when it's so high, it's effectively not pumping. It's pumping too quickly to effectively move. Also, if it's under control, we would probably say that your anticoagulation is correctly dosed to keep you in the therapeutic range based on whether you only have atrial fibrillation or if you have any type of device placed in your heart, whether it's a valve or a stent. That will determine what therapeutic range you should be on. So if you're in controlled atrial fibrillation, those are the parameters. Is the rate controlled? Is the rhythm controlled? If you're being treated with a medication for rhythm control, is it effective to prevent you from being atrial? Well, okay, if the only medication given for atrial fibrillation is Eliquis, that would mean that your rate is in a range that is acceptable. The rhythm may be paroxysmal, meaning it's in atrial fibrillation. Sometimes it's in normal sinus rhythm sometimes. And if the only medication was Eliquis, then it would be controlled if it's properly dosed and your blood test shows that you're in the therapeutic range. During his 50s.
I notice you haven't mentioned the Watchman that we hear so much about.
So the Watchman device was actually shown on that screen. The effect of the Watchman is to go into the left atrial appendage, which is that side room of the left atrium, and close it off to prevent any clots from entering into the circulation. So we had one slide on it. I may have gone through it too quickly, but that was the Watchman device.
It actually allows you to manage atrial fibrillation without a blood thinner. So people who, the unfortunate thing is there's some people who are such risk for bleeding that it's maybe they fall frequently or have some, or maybe they've had different bleeding sources in their gastrointestinal tract. Having the Watchman eliminates the possibility of a blood clot from the heart, so you don't have to take the Eliquis or the warfarin.
Well, why wouldn't one choose a Watchman instead of taking Eliquis all their lives?
It's an invasive procedure. It's always a choice, but I'd say nowadays most people do choose it, given the option. Did you have a question?
You haven't mentioned blood pressure. How does blood pressure interact with all of these things?
Good question. You know, blood pressure can be high or in normal range, and a patient still have atrial fibrillation. So a patient can be treated with hypertension. So some of those beta blockers that we use to try to bring the rate down can be used, especially if the patient has high blood pressure as well. The calcium channel blockers also. So those are medications that could be used. If a patient's blood pressure is too low, we would be unable to use those medications to bring the rate down because it would cause their blood pressure to be too low, if that makes sense.
Well, thank you all for your involvement, your questions, your attentiveness. I didn't see anybody go to sleep. So they get a higher mark because of that, the sleep factor. So